And welcome to the webinar. I am Dr. Iorio, Dean of Continuing Education, Chairman and Professor in the Department of Medical Sciences here at the New York College of Podiatric Medicine. I will serve as your moderator this evening. Any questions during this evening's performance, kindly put them in the Q&A. At the end of the program, we will have discussion with our speakers. Tonight's topic is science and practice. The role of oxygen in the management of large, painful wounds. They will be presented tonight by two of our speakers. The first speaker will be Dr. Amanda Killeen, who will be focusing on animal studies, followed by Dr. Charles Andersen, who will present human studies and a comprehensive overview of topical oxygen. Upon successful completion of tonight's webinar, you will receive 1 credit hour. Physicians, physician's assistants, nurse practitioners, and podiatrists. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council on Continuing Medical Education through the joint providership of Affinity CE and the New York College of Podiatric Medicine. The New York College of Podiatric Medicine is a provider of CME in podiatric medicine by the CPME. This event is estimated to be 1 CECH hour. Affinity CE is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. Affinity CE designates this live educational activity for AMA PRA Category 1 credits. Physicians should only claim credits upon the extent of their practice in this activity. Nurses, the C continuing education is provided for this program through the collaboration between the New York College of Podiatric Medicine and Affinity CE. Affinity CE is accredited as a provider of nursing continuing professional development by the American Nurse Credentialing Centers Commission on Accreditation, ANCC. This activity provides 1 credit hour for nurses CE credit. This activity this evening is supported by an educational grant from EO2 Concepts. Our first speaker this evening is Dr. Amanda Killeen. She is a podiatrist who received her Doctor of Podiatric Medicine at the Barry University School of Podiatric Medicine, had gone on to do her podiatric residency at the Southern Arizona Veterans Administration Healthcare System, and has moved on to do a fellowship at the University of Texas Southwest Medical Center in diabetic limb salvage. She is currently a research fellow at the University of Texas Southwest Medical Center, and this evening she will be discussing her perspective on the role of oxygen in the management of large, painful wounds. Dr. Killeen.
Hi, my name is Dr. Amanda Killeen. I'm a podiatrist at the University of Texas Southwestern Medical Center in Dallas. I'm a member of the diabetic limb salvage team in the Department of Plastic Surgery, and I'm an assistant instructor as well as a research fellow. So today I'm going to talk about the science and practice of the role of oxygen in the management of large painful wounds, specifically in animal studies and bench work. I do a lot of research, so I have these disclosures. By the end today, I'm hoping that people who listen to this talk will be able to review the role of oxygen in wound healing, to define reactive oxygen species in general, and then to explain the utility of topical oxygen and pain within the animal studies I'll discuss. And to start off, I'm going to start in a probably different spot than you would expect. And I'm sure you signed up for the talk thinking, wow, this is not at all the direction. And that's good. I like to start with something that brings in new information to something I may be familiar with already. So where we're going to start here is with hemorrhoids and Saccharomyces cerevisiae. To set the stage, back in 1976, somebody somewhere within a company that is very well known for having a hemorrhoid treatment, and somebody within the FDA had decided, hey, there is something going on with a skin respiratory factor that they can pull out of Saccharomyces cerevisiae, the yeast. basically they were saying whatever this elixir is, it's some kind of an extract. It can increase the oxygen consumption by fibroblasts within the wound. So it's worth looking into. At the time, the known effects of oxygen were that collagen formation was improved, epithelialization was supported, and that the wound strength, once healed, was maintained. So to remind you, if you're not familiar with Saccharomyces cerevisiae, it is a yeast. It looks like this on the right-hand side. So it's a little bit lumpy. It's kind of an oval shape. It reproduces by budding. You can see some of the babies here. You may be more familiar with it in different forms, such as bread. It's also known as brewer's yeast. Photo credit to me. This is a loaf that I made at home. Or you might be familiar with it in this form. Basically, what was done for this study was a few different steps of animal studies and going into a clinical study, which is typically how things work. First, they did a surgery on white rats where they created basically a wounding area. They inserted a tube for the ingrowth of the cells to be collected. And while that cell ingrowth happened, they pulled the tubes off, they weighed and measured it, and were able to see that there was an increase in the fibroblasts. They then said, okay, if it works well on rats, let's graduate up to a larger animal. So they did a study on rabbit's ears. What they noticed, though, is that central in the wound that they created, as it was healing, there was hair growth noted to the center of the wound. Back then, they had early knowledge of granulation around those adnexal structures, which we are very familiar with in wound care already. So they moved this into a human hemorrhoid model where they had 3 patients. The 3 human specimens were basically treated with this topical, and then specimens were excised surgically, defatted, and then looked under a microscope for pathology. And sure enough, when they did all the work, they were showing that there was increased fibroblast metabolism and oxygen. So go figure. Where does that leave us, though? So this extract is probably some type of a growth factor. We're familiar with this in wound care because growth factors are something that we are using topically, we're aware of in the wound healing process, and there have been a few that have been on the market, such as platelet-derived growth factor, fibroblast growth factor, and epidermal growth factor. Each of these has been marketed independently for a topical treatment in wounds, which makes perfect sense because if a wound is lacking in any way, we might as well supplement something that can help push it along. We know we're always trying to get out of that chronic phase into a more of acute stage. So this makes a lot of sense, but if you were to back up a little bit into the pathways that end up in growth factor development, if you were to supplement something like oxygen, early on in the pathway, you may be able to supplement growth factors without having to put them topically. So a quick note about ischemia versus hypoxia when we're talking about wounds. For ischemia, I wanted to make the point that ischemia is more of an anatomical issue. So this is an inadequate blood flow because something is blocking the flow. This is one of my patients. Unfortunately, he occluded the anterior and posterior tibial arteries. So what you see here is an entirely dead forefoot, at least until the midfoot. You can see the arch is all blackish purple as well. In this case, he had a blockage that occurred and stopped all the blood flow. It could be something like an occlusion. It could be something like a laceration. It could be all different kinds of reasons, but ischemia is preventing the flow from getting to the area of concern. When we talk about hypoxia, this is more of a tissue level. So this is blood is getting around to the area, but is it really that the oxygen is being transferred into the tissue cellularly or not? So you can have an inadequate perfusion of oxygen, a hypoxia that's caused by ischemia, but they're not necessarily. This is a hyperspectral image. So this is a plantar left transmetatarsal amputation. It's the same orientation as the foot that's next to it. So what you see here is red. Everything here that's red is very well perfused. In the center of the wound there, you can see kind of a yellowish and greenish color. What that's showing is the yellow is kind of moderately perfused, and then the green is the least perfused. This is an important point to make because in the center of the wound is the least perfused, so that's the most hypoxic area. Then there's a gradient that goes from the least to the most perfused from the center to the periphery of the wound. This is a point I'll bring up a little bit later in an animal study, but I wanted to point it out visually because this is how I'm able to get new information. So the question then is, why is oxygen so important? everybody knows the mitochondria is the powerhouse of the cell for a reason, because it is that important. So since we've all been through biology and chemistry, we can understand a little bit better. Oxidative phosphorylation that occurs in the mitochondria accounts for about 90% of the oxygen consumption in humans in general. So there will be several points in this talk where I have pretty complex diagrams. The point of this is just to remind people, if you know everything in this diagram, great. I'm not going to go step by step here. But if you are a student, go ahead and learn every single thing on here because it is important. But if you're already a clinician, you know that we don't really refer back to this often. We just need to know in general. So the most important part here on complex 4, you can see that this is where oxygen is taking place at the very end of this electron transport chain. The end product is ATP, which powers most pathways in the body. So this is extremely, extremely important. But what exactly is a reactive oxygen species? I hinted at this earlier, something that we were going to talk about. Again, I like visuals. So on the right-hand side, I have a various different group of different reactive oxygen species. It's a term that is used to describe a lot of different molecules, not only one. So what we're familiar with on the top left is oxygen, plain old O2. This is our usual elemental form. Basically, this is the one that's floating around in the air. If you look underneath it, you can see hydrogen peroxide. So it's the O2, and then there's a hydrogen on each side. So one hydrogen per oxygen, essentially. And if you remember to chemistry, the valence electrons are very, very comfortable having 8 in the outer shell. So here you can count them up with between all the sharing, there are 8. So this is an extremely stable molecule. But what happens if you don't fill up that outer shell? That's when things get reactive. On the top middle, this is the superoxide anion. You can see they made one of these electrons red. I don't know. So essentially what they did was they added an electron. So that's adding a negative charge. And because there's still one empty spot, this is a very reactive ion. It's ready to do something. It's got an extra spot to fill on that valence, and it is ready for any kind of reaction that can get it some more electrons. So it used to be thought that a reactive oxygen species was only detrimental. And it used to be that we were kind of blaming all sorts of metabolic stress, that we were blaming aging in general, everything from wrinkles to cellular stress and waste products. It turns out that that's not quite the case. Like anything, it is dose dependent, if you will. So if you have a high concentration of a reactive oxygen species, it can be detrimental. But at a low level and a low concentration, these are very important to wound healing. Especially because almost all the cells in the wound environment contain the enzyme NADPH oxidase, which is the enzyme that helps turn oxygen from the one we see on the top left into the one on the top middle where it's charged. This is something that you're familiar with. You may not have thought about it in this context before, but in the phagocytic cells that respond to initial wounding, like phagocytes, neutrophils, for instance, they use reactive oxygen species intracellularly for the respiratory burst that allows them to get rid of pathogens once they've been engulfed. So here I have our good old buddy, the neutrophil on the top right. Just to remind you what they look like, these are our best friends in wounds, helping protect from infection. But when I mentioned the concentration, when we use things like hydrogen peroxide in a wound, we're using 3%. So again, if this were a higher concentration, then that could be cytotoxic. The great thing, though, is that there is a feedback loop between reactive oxygen species and growth factors. Growth factors require the reactive oxygen species to work on cells, so this makes a lot of sense. Another diagram here on the right-hand side, I just wanted to show here that on the left portion, right under where it says NADPH oxidase, this is within a phagocytic cell. You can see the O2 is then going into a charged particle right under those words. And then it goes to hydrogen peroxide within the cell. So exactly describing what we're kind of familiar with. And here is our classic over-the-shelf, no name brand, 3%. I wanted to bring up Gordillo's paper here. They have a really nice diagram on the right. I apologize, it's a little blurry. I had to crop it out of a paper. Basically, they're showing exactly this process where the oxygen through the use of NADPH oxidase is going to that charged particle, and then how it works throughout different stages of wound healing from the initial injury all the way. So initially, you can see platelet aggregation, disinfection, all kinds of things, chemotaxis, stuff that we were very familiar with and need to happen for a wound to heal completely. The point that they make here, though, is that hypoxia can trigger angiogenesis, but it doesn't sustain it. So essentially, if there's an area of concern where there is not enough blood flow, ischemia, or not enough perfusion, hypoxia, then the growth factors there can be stimulated to start angiogenesis. But once that started, then different growth factors take over. Through the work that they did, though, they were able to show that supplementing oxygen accelerated the vessel growth, which was maintainable. And it may not be necessary for that supplemented oxygen to be delivered with pressure. Let's talk about a few specific studies here. Knighton's group did a rabbit ear chamber study where they were essentially looking at the tissue gradient of hypoxia. If you think back to that picture of the hyperspectral image that I showed, the tissue gradient, meaning that the most hypoxic area is in the center of the wound, going all the way out to more and more perfused, essentially to the wound edge. That gradient is needed to have angiogenesis happen. And it makes perfect sense because if that gradient is destroyed, capillary growth stops. This is a built-in feedback loop. If the angiogenesis was not needed at all because there was perfect perfusion across the whole wound, there'd be no need for it to continue. What they showed, though, was that even inspiring extra oxygen, those concentrations positively affected the rate that the capillaries were able to grow and the density of those capillaries. This is one of my favorite studies. So Rao's group did a rat hind limb study here. I had to put the picture on the top right. This is the little chamber that they made to apply the oxygen topically. They did 24 rats. Half of them they treated with oxygen, half that they just wounded and let heal normally. What they showed is that the healing time was significantly faster when you apply oxygen, 12.8 days compared to 14.7. An interesting fact, though, is that when you look at the pictures on the bottom right, you can see the wounds are all the same size on day 0 when they're created. And over time, you can see they do get smaller. Within days 1 through 3, histologically and pathologically, there was really no difference when they looked at these cells. No difference in the amount of collagen, no difference in the amount of capillary growth, no difference in the amount of fibroblasts that were present. However, when you get to days 7 and 10, in that range, in the wounds that were treated with oxygen, there was a smaller amount of inflammatory cells within that granulation tissue. And their words are a rapid increase in the growth of small arteries and veins, which is great. So you can see on day 14, the wound is already healed within the treatment on the top, and then the wound is still open on the bottom, which is the one without oxygen. Another animal model here, this is a rabbit ear model by Wu's group. They decided to look at a couple different things. At the time, there was criticism that the wound models that were being used were young animals. The wounds were brand new. You don't really capture the chronicity that we see in human tissue, which is a good criticism. So they decided to do a couple of different experiments. First, they said, okay, if we wound an ear on this rabbit and compare young rabbits who are 6 months to aged rabbits who are 60, which evidently is quite old for a rabbit and very old for a lab rabbit, they said, okay, let's see if there's a difference between just the age. So on the left, under non-ischemia, these are rats who have normal blood flow. If you look at the arrows, you can see where the epithelial edge has moved away from the plane triangle. The plane triangle was where they first made the incision. So over the course of their study, the aged rabbits had 41.7% less granulation formed, which was statistically significant. And you can see this in the picture. There's a lot more space on the aged rabbit when you compare A and C. But then they said, okay, if that's the case, does ischemia basically change that difference at all? So they redid this in an ischemic model, which in order to induce this in animals, they basically dissect out and tie off a vessel that feeds the area of concern. So They redid this again using an arrow. You can see on B compared to D. In the ischemic model, the young rabbits actually healed pretty well. You can see that epithelial edge really moved. But if you look at D, there is barely a change. Those aged rabbits with ischemia had 92.9% less granulation tissue. So this is probably more applicable to our human population. But it's worth noting that animal models are just that. It's a model. It's not necessarily going to be the same when we get into a human. They serve a great purpose, though, which is that you can come up with a really interesting experiment, which is very controlled, and get good data relatively quickly. And then we move, once we know it's safe, once we know what to expect, then we can move into a clinical model. So I have another one here with a rat foot pad model. Essentially in this one, this is a good study that's bridging a gap to my next point. They formed a blister with suction on the foot pad of a rat. It's a fairly small area, but they were specifically wanting to inflame the tissue even more to see if they could change the reactive oxygen species. In order to inflame that tissue, they added substance P. Now, if you have ever eaten hot peppers, if you have ever scraped seeds off of a pepper with your thumbnail and had burning skin for 24 hours or something as specific as that, like I have, you've experienced substance P. Substance P is usually a pain modulator, but I'm going to point out that it does make a difference in wounds. Here, what they did was again used a young versus an aged model. These are with rats. So the aged rats had 60% reduced vascular response to their substance P. And here we go. Here's another big diagram. Again, I don't expect you to know all of it. The point we're going to look at here is just within the box. So what you can see here is basically the end of a nerve and the C fiber, which is on the bottom. The C fiber are the small fibers that go to the skin. These are the ones we're more familiar with. Basically, substance P can be going in either direction. Substance P also does a lot of other things that I'm going to illustrate here. So you can see where substance P on the right-hand side, there's an arrow going down toward the endothelial cells. The actions of substance P are a few. The most important ones for us are to attract immune cells to the site of injury or inflammation. Then they can cause mast cells to release histamine, which then is causing redness, heat, things like that, and acts on endothelial cells to increase the capillary permeability. Now, that is very important to us because the direct impact of that permeability is that there's edema to the area, which, if you're thinking what I'm thinking, this sounds a heck of a lot like our cardinal signs of inflammation. So calor, rubor, tumor, dolor. So it's all of these: heat, redness, pain, all of those normal signs that we see in an inflamed tissue. These can actually be modulated by substance P as well. So it shouldn't be out of the realm of us understanding that pain can be, and usually is, associated with these type of wounds. So in conclusion here, number one, oxygen is absolutely necessary for wound healing. No ifs, ands, or buts about it. But also supplementing oxygen can contribute to more reactive oxygen species and then activation of growth factors in turn. And also in animal models, we've seen a link between the modulation of oxygen and substance P within that wound healing. Thank you.
Thank you, Dr. Killeen. If there are any questions in the Q&A, please type them in and we will answer your questions upon the completion of this program. Thank you. Our next speaker is Dr. Charles Andersen. Dr. Andersen had served as the Chief of Vascular, Endovascular, and Limb Preservation Surgery Service and is currently the Medical Director in the Wound Care Clinic at Madigan Army Medical Center in Tacoma, Washington. He is well published and accomplished in wound care area. This evening, he is going to be discussing a comprehensive overview in clinical and scientific application of topical oxygen in the management of large, painful wounds. Welcome, Dr. Andersen.
My name is Chuck Andersen. For the last 20 plus years, I've been involved in a limb preservation program at Madigan Army Medical Center. I am currently chief of the wound care service at Madigan Army Medical Center. I'm clinical professor of surgery at UW and USUHS. It's a pleasure for me this morning to talk about the science and practice, the role of oxygen in the management of large, painful wounds. A couple of disclosures. First of all, I am a consultant for EO2. That's one of the companies that makes a topical oxygen system. No unapproved uses of topical oxygen will be discussed in this presentation. Important, I work for the US government, and the opinions voiced in this presentation are the opinions of the author, myself, and not the US Army or the Department of Defense. Learning objectives: at the conclusion of this activity, participants will be able to understand the importance of oxygen in the healing process, describe the types of topical oxygen systems that are available, and explain the role of topical oxygen in the management of some wounds. And I'll have some case studies to present showing the actual use of topical oxygen. So prior to my presentation, you've heard a very nice presentation that kind of laid the foundation for this presentation. Just to review that, oxygen is a critical element for the wound healing process. Animal studies have demonstrated that oxygen therapy topical oxygen therapy can increase tissue oxygenation and promote more rapid healing. Clinical studies, some very excellent clinical studies, have demonstrated the benefit of topical oxygen therapy in clinical practice. When we talk about oxygen delivery, there's two broad categories. One is inspired, for example, HBO, where you're in a chamber, you inhale a high concentration of oxygen. Generally, that's 90 minutes a day for 3 to 5 days a week. That's dependent on increasing the oxygenation level in the blood. That then goes to the area of a wound. It's obviously dependent on having enough circulation to get that hyperoxygenated blood to the area of a wound. Topical oxygen requires some type of oxygen generator. There's two broad categories again. One is intermittent. The system that's available has a large generator, often referred to as TO or topical oxygen. Again, it's intermittent, 90 minutes a day for 3 to 5 days a week. That oxygen is then piped into a bag or a chamber that encompasses the wound to create an oxygen-rich environment. Continuous is a small wearable generator applied through a dressing or a wheel. So these are the different systems to increase oxygen to the area of a wound to promote healing. This is a chart that just demonstrates the difference between the systems, HBO being intermittent, TO again intermittent, and then the continuous, showing the concentration, HBO 93 to 99%, intermittent 87 to 93%, and the through the dressing or the continuous is 99%. And the delivery, the two HBO and TO intermittent are intermittent, and then the continuous is 24 hours a day. So topical oxygen systems, TO is the oldest system. It requires, or the current equipment available has a large generator. So generally it's used in the home, which is an advantage, or it's used in a healthcare facility. It has a large generator that delivers oxygen into tubing that then is delivered to a chamber that encompasses the wound. TCO2, that's the transcutaneous oxygen with a small generator, and the CDO, again, continuous diffusion oxygen. And I'll show the difference to those. In the CDO, the oxygen is delivered through a small tubing into a diffusion dressing or a wheel. And another chart just showing the difference between the types of therapy, the intermittent and the continuous, and the power source required. In the TCO2, it's disposable batteries. In the CDO, it's a rechargeable type of a system. This compares the oxygen delivery, or the amount of oxygen delivered, with different systems. So here you see an ischemic wound and a normal oxygenation. With HBO, you have intermittent spikes of high oxygen concentration. The same with the chamber. With the continuous diffusion, what you have, because you have continuous delivery of oxygen, you have 20 times longer exposure to oxygen than the intermittent therapies. So there's some excellent, very excellent clinical studies supporting each of the oxygen delivery systems. For this presentation, because of the time allotted, I'm going to go through just one particular study. But again, there are excellent studies supporting each of the systems. So this is a study, a beautifully designed study. So the box is the oxygen generating system. It takes room air and then converts it into 100% oxygen delivered through tubing into a dressing. With the study, both the control and the treatment arm had the generators. The placebo obviously was not generating oxygen, but neither the patient or providers knew which was the active system and which was the placebo system. Each of both the control and the active had moist wound care through the appropriate dressing, and critical each had the offloading. So this was a diabetic foot ulcer study. The primary outcome for this study was full wound closure, defined as reepithelialization of the wound with no drainage. Secondary outcomes: time for the wound closure, effect of baseline wound size on wound closure, and the effect of wound chronicity on wound closure. Looking at the demographics, comparing the control with the active arm, there was no significant difference between these, the control and the active group. The wound size, these were fairly large wounds, and these were wounds that had an average of 2.4 years. So these were chronic wounds. Study results, very impressive. So the continuous delivery of oxygen significantly healed wounds better and faster, 204%. Some interesting observations beyond just the increased closure. It performed better in larger wounds, performed better in more chronic wounds, in weight-bearing wounds, in populations predisposed to diabetes. And a side study, as part of this study, looked at those centers that actively debrided their wounds versus the centers that did not make debridement as part of the care with the topical oxygen. So those wounds that were debrided, 240% increase along the debridement plus the oxygen therapy. It just shows the importance of good basic wound care in addition to the oxygen therapy. The CDO, or continuous diffusion oxygen, seemed to decrease the incidence of severe infections, 75% less. Another interesting observation of this therapy is pain relief. So this is a small study, a pilot clinical study in a group of painful wounds. This was published in Wound Central in September of 2018. Again, a small study, 20 patients, 23 wounds, 65% female, an elderly population, 74.2 plus or minus 16.3 years, and large wounds. The mean pain level associated with these wounds was 8. This is on a scale of 1 to 10. So these were very large, painful wounds. What was found was all patients reported significant pain relief. 100% went to either 0 or 1. So all except one patient with a large open wound. Interesting, pain relief was fairly rapid, generally by 4 days, although some patients had reduction of pain actually the same day as the therapy was initiated. So a side effect, many of these patients that obviously have these large painful wounds are dependent on narcotics for part of their wound management. And in this series, all patients were able to get off from their narcotics. So this is a study that is currently awaiting publication, myself and Dr. Iorio. But we looked at the literature and looked at what wounds had been reported to be of benefit with the use of topical oxygen. The wound types that were reported in the literature were diabetes, vascular ulcers, post-surgical infections, pressure injury, amputation and infected stumps, skin grafts, cellular tissue-based products, using it with those products, prevention of wound dehiscence, ischemic wounds, burns, and frostbite. So a very important technology, but one of the questions is really, when should it be used? At what point in the wound healing process should it be used? And on what wound should it be used? To help answer these questions, we did a Delphi consensus involving a significant number of wound care specialists that use the Delphi process. And this is being published this month. So the various questions that we looked at in the Delphi consensus, one is what workup and procedures should be performed prior to ordering topical oxygen therapy. And the idea is not that topical oxygen therapy should be used in every wound in a wound care clinic. So that it was felt by these wound experts, again, using the Delphi consensus method, that prior to initiation of topical oxygen therapy, there should be assessment of limb perfusion, ABI, TBI. That's important. So just like with hyperbaric oxygen, if somebody has an ischemic wound, they should be considered for revascularization prior to being committed to either a hyperbaric or topical oxygen therapy. So assessment of limb perfusion was felt to be important. Clinical assessment of bacterial load, the consensus of 75%. Nutritional assessment, consensus of 78%. Debridement, again, I mentioned the study that showed the benefit of debridement. 87% of the experts agreed. Edema management, 75, and offloading, both in the diabetic and pressure ulcers, with a consensus of 96%. In trying to figure out, again, which wounds would be considered or which wounds the experts felt that might be most beneficial. Delayed wound healing, a consensus of 100%. Failure of prior therapies, a consensus of 94%. Ischemic ulcers, again, following all efforts to revascularize first with a consensus of 88%. The experts felt that the wound types most likely to benefit from topical oxygen therapy, diabetic foot ulcers, based on the current literature available, 94%. Venous leg ulcers, a consensus of 77%. And ischemic ulcers, a consensus of 77%. I'd like to present some of my studies or my cases that I think demonstrate some important principles in the use of topical oxygen therapy. So 3 separate cases. One is a large painful neuroischemic ulcer. The second is using topical oxygen as a part of a reconstructive pathway. And the third case is a very chronic wound with exposed hardware. So this patient, very interesting gentleman, 79-year-old male, had some coexisting medical conditions, one of which was recurrent congestive heart failure. During about an acute exacerbation of congestive heart failure, he developed very large blisters on both lower extremities. One of those blisters progressed onto a large, very painful lower extremity wound. We were trying standard wound care for a significant period of time, and this wound was failing to heal. So in initiating in this chronic wound that had failed standard of care, in initiating topical oxygen therapy, we had 2 goals. This patient was on narcotics because of the degree of pain involved with this wound. And as I mentioned, the wound was not healed. So oxygen therapy was initiated to promote healing as well as to hopefully aid in pain control. So this is what the wound looked like, a fairly large wound, 5.5 centimeters by 3.9, not very deep, but as I mentioned, very painful on narcotics. This is the system. So again, addressing with the oxygen tubing going into the dressing, providing continuous oxygen onto the surface of the wound. So very interesting in this gentleman, his pain was significantly decreased within hours of initiation of the therapy. Over the ensuing 2 days, his patient was able to get off from his narcotics. This patient came back, so his wound was progressing very nicely. He came back to the clinic and said, you know, the wound is doing well. I'm not having any pain. It's healing. Let's just get rid of this little generator and let's go back to just a dressing. So we took off the oxygen therapy, put on moist wound care, used a silver alginate at that point in time. And the patient was sent to another part of the hospital. He was getting some laboratory studies and x-ray studies. Within an hour, the patient was back to the clinic, stating that he had his pain back in his wound and he wanted to have the oxygen therapy reinitiated. So the oxygen therapy was reinitiated. By that evening, the pain had again resolved. So the wound healed in 60 days with no recurrence of the wound or no recurrence of the pain once the wound was healed. So this just shows the progression. This is after 5 days of therapy, already an improvement in the granularity of the wound and a decrease in the size of the wound. This was 30 days, again, a significant decrease in the size of the wound. And this was 60 days where the wound was completely healed. At the same time, obviously, he had medical control of his edema, and he had external compression to help with the control of his edema. So oxygen therapy, along with other components of the care that were critical in this patient, but excellent healing of a wound that was not responding to our previous therapy and dramatic improvement in the pain associated with this wound. This is another case. It's a little different case, but emphasizes that this therapy can be used as part of a reconstructive pathway. This is a case of a very aggressive MRSA infection following a cervical laminectomy. So the patient had underlying hardware. So 56-year-old male with Parkinsonism had a laminectomy, complicated with a very severe wound site infection, had MRSA, required a return to the operating room with a very pretty significant debridement of infected tissue, was in the hospital on IV vancomycin until the septic picture and the cellulitis improved enough that he was discharged for outpatient management. The initial then visit to the wound care clinic, so a little less than a month. This patient had additional debridement in the clinic and was started on a silver alginate dressing, and we ordered a wound vac for a treatment of that wound. And at that point in time, there was still exposed hardware in the base of the wound. The wound was large, 9 centimeters by 5 centimeters by 3 centimeters, 3 centimeters deep with significant undermining. So the reconstructive pathway that was utilized, antibiotics, surgical debridement, short course of antibiotics and silver alginate, then negative pressure wound therapy for essentially a month. During that period, he had granulation tissue that formed covering the hardware, and the significant undermining resolved with the negative pressure therapy. Once that wound had then progressed, so the granulation tissue was at skin level, then therapy was changed to topical oxygen therapy for closure of that wound. So this is when the negative pressure wound therapy was initiated. You can see the large wound, the undermining, and right in the center of that wound, you can see some exposed hardware. This was once the negative pressure therapy had created excellent granulation tissue over that hardware and filled in that deep wound and decreased the amount of undermining. Then topical oxygen therapy was initiated. At that point in time, the wound was still 6.5 by 2.2 by 0.2. This is 30 days of oxygen therapy, 50 days of oxygen therapy, and 58 days of therapy. So a wound that not only was a very, very large wound, this was also a painful wound. And again, once oxygen therapy was initiated, this patient was able to get off from his narcotics also. But a wound that when you have exposed hardware, that can be something that obviously can lead to infection of that hardware and the need to remove that hardware. So using a reconstructive pathway, adequate debridement, antibiotics, negative pressure therapy, and then topical wound therapy, we were able to get that wound healed. No need to remove the hardware, and this patient returned to a good level of function. So this is, again, shows the wound when topical oxygen therapy was initiated, and then you see the closure of that wound. This is another very interesting patient. This patient had had a wound present for a year. This patient had a neuroischemic wound. He had a degree of vascular insufficiency and a degree of neuropathy. This wound was initially created with a brace previous operation, and there was exposed bone cement from his previous operation in the base of that wound. And you can see the dressing with the oxygen delivery. And this patient went on to heal in 6 weeks. Again, had been present for over a year. So in conclusion, this, at least in our experience, it has been a very useful modality that helps heal very large and painful chronic wounds. Some key questions are still, when should it be used, at what period in the healing process, and on what wounds. We hope the Delphi consensus gives some guidance to when that should be used. And the other very important finding is that in addition to promoting healing of these large wounds, that it significantly decreases the pain associated with these large painful wounds. It's been a pleasure to share this experience with you, and I look forward to a discussion on the presentation. Thank you very much.
Thank you, Dr. Andersen, for your kind presentation, and we will begin our discussion.
This is the first question. What is the preferred method of application? I think I'll give it to both Dr. Andersen and Dr. Killeen, if you can comment on it, please.
I think the clinical studies demonstrate that the systems that are currently available have evidence to support their usage. So I think to some degree, it's a user's option. On the other hand, the larger devices, I think, are for home use and intermittent use. The advantage, perhaps, of the smaller generators is that those can be worn and patients are not tethered to a big machine, and they can go about their business. So we personally prefer the smaller units, but there's evidence supporting each of the units.
Mm-hmm. And I'll echo Dr. Andersen. I'm also familiar with several types. The intermittent ones are more when the patient is sitting at home. You don't have to take offloading into account during the treatment because they'll be sitting on a recliner, for instance. But if you are doing a continuous form of topical oxygen, I think it's easiest to do it on a non-weight bearing surface unless your patient is properly offloaded and totally non-weight bearing on the plantar surface. It's just something I've come across where either they shear it or there is an issue with the tubing. It's easy to fix, but your patient has to be fairly aware just to make sure they're checking it.
Thank you. Next question for both of our panelists. What are your thoughts when we are unable to surgically repair the peripheral vascular patient? Is there a role for continuous diffusion of oxygen?
I'll take that one first. So certainly, as I emphasized in my talk, if somebody has ischemia, that should be evaluated, and if patients are a candidate for revascularization, that should be the first line of therapy before committing to hyperbaric or even continuous oxygen therapy for a prolonged period of time. On the other hand, there's a group of patients that we are unable to directly revascularize, and those patients have continued levels of ischemia, and we have been able to heal some of those wounds using topical oxygen. The animal studies again demonstrate that the topical oxygen does penetrate the skin into the area of the wound, so that even if you have inadequate direct blood supply, applying it topically, you can at least get oxygen into the area of the wound.
I had a similar patient to your first case, Dr. Andersen, where the patient had an arterial ulcer, but had a lot of pain and was not a candidate for surgery for any revascularization. So we thought, well, we might as well try. And the patient was so happy. He had no change in the wound initially, but he said, I know it looks the same, but it feels so much better. His pain went from like a 9 to a 2 over the space of a week and a half, which is huge. It was huge for that patient. So even though we weren't able to fully heal the wound, we were still able to get it so it was manageable and it wasn't interfering with his life, which sometimes is the goal, not just healing everything else.
Something that Amanda touched on that I think is very, very important is, in addition to the topical oxygen, we can't forget about the basics of wound care, and certainly in a diabetic foot ulcer, offloading is the first line of therapy. So you can't just put on a dressing and forget to offload that patient.
Do either of you know if there are any studies on ischemia patients in particular? A question from our audience. I gather not, that I know of. I don't know if you're familiar with any, but I'm not.
I'm not prospectively. Normally the prospective studies for any of these types of devices have a pretty narrow window of what patients they want to enroll. So the studies can be well laid out, but keep in mind that your most sick patients are not represented in those. If your patient has a 0.3 or a 0.4 ABI, they're definitely not enrolled in those type of clinical studies. So that's where the value of having a retrospective or even a case study or a case series to explain, hey, we don't have a lot, but this is something that may be useful. There's still value in those small cases.
Right. Another question, can oxygen generating compounds such as those used in rebreathing systems be incorporated into the bandages?
Amanda, do you want to?
Interesting. I'll start. I'm familiar with a few studies where there were basically super oxygenated emulsions that were used topically. Most of those were done in burns. I'm not sure that they jumped into a chronic wound or diabetic wounds, but those were done in the early 2000s in dermatology specifically. So I'm not sure if they've made it into my realm in podiatry at least. It's a potential, but I haven't seen it marketed yet.
Okay.
I have no experience with oxygen generating dressing.
Okay, thank you. You mentioned, Dr. Andersen, that you use a wound vac. When is it appropriate for a clinician to perhaps translate from a wound vac into topical oxygen? Is there some way in which you can perhaps lead us or in some of your protocols that you may have that could help answer this question?
I tend to approach a large wound as a reconstruction of a complex tissue defect, and there are various steps, obviously starting with assessment of perfusion or oxygenation, moving on to debridement, revascularization if required. In large wounds, we find the wound vac very helpful as an initial therapy, but you reach a point where, number one, the wound stops contracting with a wound vac, and the granulation tissue is flush with the wound. I think at that point in time, you've really reached the maximum benefit of the wound vac as far as continuing therapy. And that would be where we would transition to some other therapy to support coverage, to support reepithelialization. And just as I demonstrated in that one wound, that would be where we would then transition to some other type of therapy, one of those being oxygen therapy.
Okay, thank you. Would one consider the concomitant use of some additional device such as skin substitutes or placental-based allografts in addition to utilizing the topical oxygen, or in this particular case, the continuous diffusion of oxygen? Have either one of you had experience with concomitant therapy?
Yes, we do that fairly commonly. Use of dermal matrix tissue or some other biologic, and then combine that with oxygen therapy. I don't have any scientific data to support that, but clinically, we've had very good response using the combined therapy.
Dr. Killeen, have you had any experience with concomitant therapy?
Not for this, no. I've used the continuous diffusion just over regular wounds after debridement. I haven't done any additional products with it. I usually just do a negative pressure, so couldn't say.
Okay, thank you. A question comes in from an attendee wanting to know if hydrogen peroxide is still used. It's being mentioned. I was wondering if you can comment on that, if you use it, if you don't use it, and perhaps the reason for using it.
So it is kind of an old school belief that never use hydrogen peroxide because it's going to be cytotoxic. It's going to kill all your top layer of good, brand new baby cells that are just coming up. It's not really the case, but it really does go back to what I was mentioning, which is how much concentration are we talking about? The over-the-counters are really pretty safe, especially if we're just using them as a flush, where we're going to be debriding that top layer anyway. It doesn't do much. I definitely tell my patients not to do it. I have patients who will douse their wound in peroxide and or alcohol multiple times a day. And no, that's too much. But for our use, we're pretty judicious as wound care practitioners. I think it's totally safe in our hands. And it's not as scary as I think we were led to be believing earlier on.
Okay, good.
We'll use hydrogen peroxide in a wound where there's a hematoma and evacuated that hematoma, but there's still adherent blood in that the cavity, the wound cavity. And using hydrogen peroxide can, in that acute stage, not as a chronic therapy, but in that acute stage where there's adherent thrombus, that'll remove that very rapidly.
Okay, thank you. And our last question, and if there are any more, kindly type them in. If not, our last question for the evening and this discussion will be, have you used continuous diffusion of oxygen to close a wound? Anyone? I'll open that up to either or both if you'd like to comment on that.
Yes, certainly that's our goal, is to use that therapy until you get to the appointment of closure. And we've closed many wounds with the continuous therapy, continuous oxygen.
And I interpret that question to mean more surgical closure. So I have also used a continuous on top of basically the incision line. We had to do a T shape of a closure for a transmetatarsal amputation. And it was a patient who had pretty severe diabetes. He had been revascularized once. It was as good as they could get. His flap was a little bit dusky. He was a dialysis patient. And so I thought, well, this may help. And he did not lose the whole flap. He necrosed very, very minimally on that incision itself, but we're able to prevent it turning completely necrotic.
Well, thank you, Dr. Killeen. Thank you, Dr. Andersen, for a very informative evening and webinar. And I'd like to thank Affinity for your kind assistance in putting this all together. With that, this is the conclusion of this evening's webinar. Have a great evening.